Welcome, my name is Azim. I'm one of the co-founders of BiteMedicine. I'm a doctor in central London. And it's great to see so many of you here, as always, really. I mean, for many of you, this may be your first webinar, BiteMedicine webinar. For others, you may have been along the journey. This is now our 84th webinar. So it's great, once again, to see lots of people tuning in. Obviously, we have lots more webinars coming up. We've got a whole bank of webinars available in our video bank. So do check those out as well. There's been a slight change in topic. This was initially going to be the ABG interpretation webinar, but obviously interpreting ABGs is slightly pointless unless you have a reasonable understanding of the physiology and theory. So I wanted to focus on that initially. If you feel like you have a good understanding of this already and you know about bicarbonate and you know about where it's made and you know, etc., then feel free to tune in just to the interpretation one. Otherwise, stick around. And when we get on to the interpretation webinar next time, you'll have a very good baseline level of knowledge for us to build on. So this is nice, straightforward, physiology, pathophysiology, and theory. Ask questions as we go along, as always, and I'll try and mop up any other questions right at the end. Cool. So as always, our target audience is our clinical year medical students, physician associates. I suspect this will be around 45 minutes long. It's not massively complicated. I don't like overcomplicating this topic because it's very easy to overcomplicate arterial blood gas theory and physiology. And that's not what we're here to do. If you know BiteMedicine, we like to simplify things. We like flow charts, we like animations, and we like interactive questioning. So that's what this is going to be today. So if you're not aware, we usually use a system called mentimeter.com. So either you can open up another tab, you can open it on your phone, wherever it is, and we can do those interactive questions together. When I designed this webinar, it was based on lots and lots of questions that we've had teaching, thousands of students during COVID. Lots of questions like, when am I going to do a VBG? When am I going to do an ABG? Do all patients need an ABG? Which patients need an ABG? How do you interpret ABGs? Of course. And that's why I wanted to focus on some of those as well, because I want to kind of demystify some of those common misconceptions. So without further ado, let me make a start. So I'm not going to dwell too much on this. You've come through our platform. If you have time, do check out our online textbook and our question bank, all based on the most recent evidence, all based and built by clinicians in the UK and reviewed by specialists as well. So yeah, if you have a chance, do check that out. So I'm only going to really include one case-based discussion today, mainly because this is obviously a lot of theory and going through a bunch of cases this time round is not massively beneficial, but in our interpretation, of course, we'll be going through lots of different cases. So let's have a look at this one. So we have a 65-year-old male. This is really just to get us into the mood. It's nothing extravagant, this question. A 65-year-old male presents to the emergency department with a 3-day history of worsening difficulty breathing and non-productive cough. He reports feeling feverish, reduced sense of taste. There he is, puffing away. He has a history of asthma, type 2 diabetes. He smoked 2 cigarettes a day for the past 3 years. So there he is with his fever and puffing away. I love his moustache. I had to put him in because he had a moustache. Look at his observations. What do we think? What do we think? Just the obs. You can pop it in the chat. Any concerns? Are we happy? Are we unhappy? And why? Yeah, oxygen saturations are low. 88, that is low. He is tachycardic at 105, his rest rate is high, and he's pyrexial. So the only thing that is normal, if you want to call it that, is the blood pressure. But as we know about blood pressure in unwell patients, particularly in patients who are going into shock, that blood pressure is the last thing to drop. So don't be falsely reassured by that blood pressure. But yes, everything else is abnormal. So I would be concerned as well. What is the most likely diagnosis of this ill patient? Now, this is what I thought I'd ask a nice, easy question to open up with. If you don't answer in the chat, if that's okay, all our questions are going to be on Mentimeter. So if you head over to menti.com, wiki.com and type in that code at the top there, 1875511. But yeah, this is a nice, easy question, and hopefully for our purposes, you will get this correct. We have lived through this. This is a nice and easy question. Good. This is a reminder, you know, we're in lockdown. Let's all try and follow the rules. This is exactly COVID. This patient will need contact tracing, and this patient will need probably steroids, azithromycin, erythromycin. The only reason this isn't, I mean, the main reason this isn't undiagnosed CVD exacerbation is because obviously he has a very minimal smoking history anyway. And as described here, you know, you'd expect a wheeze, and this patient hasn't presented with a classic history of an exacerbation of COPD. But all these slides will be uploaded if they haven't been already with all these explanations. But this is just a reminder, and me sending my thoughts out to everyone during the second lockdown. I hope you are all well. And obviously this is a history of COVID, which we are seeing a lot more in A&E at the moment. So, and these are obviously the reasons why. You've got difficulty breathing, non-productive cough, feverish, loss of sense of taste, probably smell as well. Asthma, diabetes are risk factors for severe COVID, and obviously he's got some deranged observations. So that's COVID. Now, let's move on to ABG. So this patient here with COVID, in you know, probably in respiratory failure, if you actually look at his gas, will need obviously an arterial blood gas because he's in respiratory distress. We need to know his PO2 and an accurate representation of his PCO2. So that's an example of a patient that would need an arterial blood gas during their time in A&E. So we'll start off at the bare basics because we like starting at that point, so everyone's at the same level. What is an ABG? So an ABG, really simply, is you take a needle, take a syringe, and directly take a sample of arterial blood, most commonly from your radial artery, obviously, which is over here. And there are other places you can take arterial blood gases from, such as your brachial artery, your femoral arteries, but on the whole, radial artery is easy to access. It's not a deep artery, therefore it's relatively straightforward to gain access to, and it has a good collateral circulation in case things go wrong. So we'll explain what I mean by when things go wrong very shortly. But yes, radial artery, this is a really important clinical skill that you need to try and master, ideally during med school. I know it's difficult to find patients that are willing to do this on because no one likes having an arterial blood gas done. But that's essentially what it is. You can do femoral artery sampling, like we've said, these are called fem stabs, and often done if you need larger samples or if it's difficult to get access at the radial artery. Nice. So the reason why I've included this case and we've started off at the basics is because I really want us all to actually imagine that we are junior doctors, we are physician associates working in A&E, working on the respiratory wards, wherever it is, anywhere where patients get acutely unwell, which is essentially the entire hospital. I want you to imagine actually being there, because in a few years, maybe even less than that, you are going to be in that position. We need to, I'm not going to dwell on how to do an ABG today. That's not the purpose of this webinar, but I want you to actually put yourself in the shoes of someone who's involved in this process. And as you can see here, you know, you've got unwell patients, you've got your syringe, you've got your blood gas, and you need to know how to do the test, and you need to know how to interpret it as well. This is how we interpret or how we get our results of our ABGs. So the fantastic thing, if you didn't know already, about venous blood gases and arterial blood gases is that it's essentially a point of care testing system. It's done not necessarily exactly by the patient's bedside, but the sample is taken. That usually just takes a few moments. You take the sample, you've got it in your syringe, and you take it to the blood gas analyzer. And I know you can't see the exact values on the screen there, but you can, you know, that's going to include your things like your pH, your bicarbonate, your PO2, your PCO2, lactate, some electrolytes such as sodium, potassium. These are all such useful initial results to have by the patient's bedside, essentially, and really quickly like that. And that's why it's so useful, particularly in the emergency department, because you can get those results so fast and optimize the patient's management quickly. And that's why we love particularly venous blood gases, but also arterial blood gases as well. So what is the difference between a VBG and an ABG? And this gets onto that concept that all students seem to ask me is, when am I going to do a VBG? When am I going to do an ABG? Obviously, the main difference between a venous blood gas and an arterial blood gas is that a VBG takes a venous sample, for example, from your antecubital fossa, and arterial blood gas takes an arterial sample, like we said, example, from your radial artery. Now, we've talked about how you do an arterial blood gas. It's literally a needle, syringe, you take the sample. How you do a venous blood gas, essentially, like you would take a blood sample from your antecubital fossa, as you can see here. Often you just take, pop the needle in with a butterfly attached and a syringe attached to that, and you just take a nice simple venous sample. It's so easy to do. And actually, venous blood gases are now kind of widely used in the emergency department in preference to arterial blood gases. There was quite an important paper published back in 2001, which really showed that there was a big agreement between venous blood gas results and arterial blood gas results. And we're going to talk a little bit in more detail about that as well. Particularly pH, so venous pH, arterial pH, there is a pretty good correlation between the two. But there are some limitations to that, which I'm not going to get into, but there is a pretty good correlation between a lot of the values you get on your arterial blood gas and your venous blood gas. So I guess the question is, why are we going to be doing arterial blood gases at all? And that's what we're going to be talking about shortly. So which of the following is true regarding blood gases in general? And this is kind of going to lead us on into this concept of comparing VBGs, ABGs, and getting a better understanding of that. So, yep, looking at Andrew's question in the chat, just to be clear, an ABG machine will analyze VBG. Absolutely correct. You can take an arterial blood gas or a venous blood gas sample to the machine, the blood gas analyzer, and you can then on the machine set whether it's an arterial sample or a venous sample, and it will analyze it accordingly, because obviously the values are slightly different. So technically it's not an arterial blood gas machine, it's a blood gas analyzer, because you can do either. Cool. Anyone else looking to answer this question? So the majority of you have put this answer here, which I was suspecting that you would do, because it's a nice, relatively straightforward question as well. An arterial blood gas is required to determine PO2, naturally, because to get an accurate representation of a patient's essentially partial pressure of oxygen, you need an arterial sample. A venous sample is wildly inaccurate on the whole when you're trying to assess PO2. And that's a big limitation of your venous blood gas. Not all patients with diabetic ketoacidosis require an ABG. These patients usually require serial venous blood gases, because you do need to look at the pH, you do need to look at those parameters and see whether they're improving and the acidosis is improving as well. But they don't need an arterial blood gas. And a big point here to mention is that an ABG is very painful. Current guidelines do say use local anesthetic. When you're doing an arterial blood gas in clinical practice, I've only seen a couple of times people actually giving local anesthetic, because it is a very painful procedure. And I was reading a study a few weeks ago, patients, particularly with chronic respiratory disease, who, when they present to hospital, require ABGs, they present very late to hospital because they're actually trying to avoid getting arterial blood gases done. And that's a big reason why the emergency department is now kind of favoring venous blood gases, except in certain situations, because we want to avoid those situations happening. If people are avoiding going to hospital because of a painful procedure, then we don't want that to be the case, unless it's 100% necessary. We want to avoid arterial blood gases. Now, a really important slide here is the correlation between venous blood gas and arterial blood gas, because the question is, if venous blood gases are so great and they're not painful, etc., why are we not doing them more often. Well, we are doing them very often, but why do we prefer ABGs in certain circumstances? Well, these are the real parameters to be aware of when comparing VBGs and ABGs. So pH, good correlation between the two. As you can see, the differences are quite negligible between a VBG and an ABG. That's good. PO2, obviously the big thing that compares poorly. If you need an accurate representation of the patient's PO2, you will need an arterial blood gas. Obviously, pulse oximetry is great. There are a few limitations which we'll touch on shortly, but that's a really important point, which the majority of you got on the previous question anyway. PCO2, there is a relatively good correlation between PCO2, between a VBG and an ABG, if the patient is normocapnic. In other words, as I've written here, if the venous blood gas PCO2 is normal, you can exclude hypercapnia. This is a theoretical statement because there is some conflicting evidence for this. On the whole, in my clinical experience, this is relatively true, but not all the time. So that's not. I know that's not particularly useful, but that's why the jury is still out as to how we can take into account that conflicting evidence. Bicarb, good correlation between VBG and ABG. Lactate, theoretically, there's descriptions in the literature about a dissociation once a patient's lactate goes above 2. Often in clinical practice, is not clinically significant. If on a venous blood gas, the patient is systemically unwell, for example, they're septic, and on a venous blood gas, their lactate is 8, that patient is unwell. Taking an arterial blood gas, unless there's a specific reason for that, if it's just to look at the lactate, it's probably not going to be massively important. Although theoretically, as I said, there is a dissociation there above 2. And base excess, there's a good correlation. Fine. Just looking at the chat, if there are any audio issues, etc., just below this video, you can look at the meeting info, and that should take you to Zoom externally as well, which should resolve any of those issues. Now, pros and cons of arterial blood gases in general. Obviously, the big pro is that it is the gold standard for assessing those metabolic parameters that are so important: pH, PA, CO2, bicarb. And obviously, it can actually assess your PaO2, whereas a venous blood gas cannot be used to assess your PaO2. So those are obviously the big 2 pros of an arterial blood gas sample. As with anything, there are cons, quite a few cons here. Like we said previously, a VBG is generally sufficient to assess a lot of those parameters, pH, bicarb, base excess, for example. SpO2, in other words, oxygen saturations on a pulse oximeter, is generally actually adequate to guide a lot of clinical decisions, except, for example, if the patient is significantly in shock, and a few other circumstances when a pulse oximeter may not provide reliable results. On the whole, in a lot of clinical situations, that pulse oximeter is going to be quite useful. And that may actually avoid you doing an ABG anyway. As we said, really painful. Patients avoid going into hospital because of it. There are vascular complications which can occur, as mentioned here. These are obviously far more common and prevalent with an arterial blood gas sample compared to a venous blood gas sample. And then obviously things like nerve injuries, digital ischemia, etc. So this is why I don't want you, when you start your F1, F2 jobs, or you start working as a PA, I don't want you to dive in and do ABGs on everyone. And this is precisely the slide why. As I said, we're leaning more towards VBGs, except in specific clinical circumstances. And most of you are probably now wondering, what are these specific clinical circumstances I need to do an ABG in if VBGs are pretty good anyway? Here are a few examples. Obviously, these are going to vary a little bit. These are not black and white. And there are going to be other examples when you may need to do an ABG, but here are a few of them. Respiratory failure, patient that presents to A&E, for example, in respiratory failure, they're going to need, or like significant respiratory distress. You then need to determine their PO2, determine accurately their PCO2, determine which type of respiratory failure they're in accordingly. And then obviously, because obviously management differs between type 1, type 2 respiratory failure. The patient's in shock, you're attending a cardiac arrest call, peri-arrest as well, potentially. Patients who are ventilated, patients who are undergoing sleep studies, all these patients need arterial blood gas samples for the reasons we've already described. As I said, in terms of lactate, theoretically above 2 millimoles on a VBG, there's some suspicion that maybe that's not entirely accurate, but as I said, a lot of patients with lactates above 2 are not going to need an arterial blood gas sample just to provide a more reliable measure. It's actually rarely required. Okay, so that is great. Now, as I said, this webinar is not about ABG interpretation as such. It's more about understanding what all of these values are that we're looking at on our arterial blood gas and our venous blood gas samples as well, really. But we're going to be obviously talking more about the physiology and the theory as well. So, nice, easy question to lean us into this next part of the webinar. So a patient is assessed in A&E. An arterial blood gas sample is taken. The pH is 7.29. What is this defined as? Let me bring this up and see how you guys get on with this. It's a really important. This is like leaning us into our concepts, our terminology, making sure we're using the right terminology when we get on the wards and things. I'm just going to have a look at the chat as well. Hopefully, these technical issues have now been resolved. If they continue, let me know. Can we download the slides? Yes, they should now be uploaded, I'm sure, and they should be downloadable. Okie dokie. Let's have a look. Ah, here we go. So I'm so glad to see this. I'm not glad to see that a lot of you got this incorrect. I'm glad to see that this is a learning point and a talking point. So this is, once again, as I said, about terminology here. I'm a bit of a stickler for terminology when it comes to ABGs because the things are technically a little bit different. Everyone says alkalosis, everyone says acidosis, but if we're learning things technically and in terms of terminology, this patient here with the low pH is acidemic because their pH is low. They're not acidotic because acidosis actually describes these processes that we're about to learn about that lead to acidemia. So although in clinical practice you're always going to say acidosis, metabolic acidosis, respiratory acidosis, in those terms, yes, those are correct because you're describing those processes. But this patient is acidemic because, and conversely, a pH above 7.5, the patient would be alkalemic. And it's acidosis and alkalosis are describing the process that leads to acidemia and alkalemia. So hopefully that makes sense. And as I said, this is more a question of terminology. And once you start doing your advanced life support, etc., they're very, very tight on the terminology that you use as well. And obviously, you can't say this is respiratory acidosis because we don't have enough information to define that. And we're going to be talking about that now. So moving on to some diagrams and some learning. So we've already talked about this concept of acidemia and alkalemia. Now, we're going to talk about pH. So pH is obviously a measure of the degree of acidity or alkalinity of your blood. Now, small changes in your pH represent big changes in your hydrogen ions. So the more hydrogen ions you have, the more acidic your blood is and the lower your pH is, which is essentially what this is showing. So your blood pH is less than 7.35. It's the same as saying you have an increase in your hydrogen ions above normal, which is the same as saying acidemia. So, and conversely, exactly what we're describing here on the left, your hydrogen ions are low, less acidic, your blood is more alkalotic because your pH is higher, and this is, this description of your blood pH above 7.5 is alkalemia. So hopefully this all makes sense. It's nice and straightforward. This is kind of basic GCSE chemistry type stuff. So I'm not going to dwell too much on this, but it's more about making sure you understand that terminology, the difference between acidemia, acidosis, alkalemia, and alkalosis. Because unless we understand those little bits and pieces, it's going to be difficult to fully appreciate interpretation as well. So hopefully everyone's on the same page with me there. Okay, That's nice and easy, I hope. Let's go into a bit more detail now. So hydrogen ions, as we said, the higher concentration of hydrogen ions you have in your blood, the more acidotic your blood is going to be. And obviously, everyday living produces a lot of hydrogen ions. So our body is involved in lots of different complex reactions, and therefore our body also needs to tightly control, our pH and keep it within that normal range, ideally of 7.35 to 7.45. In order to maintain that pH within that tight window, we have something in our blood called buffers. We have intracellular buffers, such as proteins, phosphate, hemoglobin, and we have extracellular buffers called plasma proteins and bicarbonate. And obviously, as I said, these buffers provide some type of solution to try and buffer those hydrogen ions, whether they're high or too low, in order to keep your pH tightly controlled. But naturally and clearly, that buffering system is only a temporary solution to the production of acids. And that's because ultimately they will all be consumed up and acids will start to reaccumulate. And therefore, a system is actually required to eliminate acids and thereby regenerate those buffers. And that's where your lungs and your kidneys come in, because we need to try and obviously maintain that pH within that tight range. And that's why these two organs are so important when we're thinking about the physiology and theory underlying ABG interpretation. Okay, so that's kind of set the foundation, hopefully, of the theory and pathophysiology. A couple of other concepts to mention: partial pressure. I'm not going to dwell too much on this. This is very kind of theoretical more than anything else. So atmospheric pressure, the partial pressure of a gas in a mixture, which is measured in kilopascals, is the same as the percentage of the gas by volume. That's a lot of words, but essentially all we're saying here is that the partial pressure of a gas, such as carbon dioxide, oxygen, is a measure of the concentration of the gas in the medium that it's in, i.e. the measure of the concentration of carbon dioxide or oxygen in blood. So when we say PaO2, we are saying the partial pressure of oxygen in arterial blood. So that's what the A is referring to, is arterial blood. Oxygen is obviously oxygen, and P is partial pressure. So that's a little bit of nomenclature, nice and easy. Hopefully you guys knew that anyway. So we've touched on pH, but now we need to understand what systems are involved in changes in pH, what's going to increase your pH, what's going to reduce your pH. Well, that's why we need to understand a little bit more about carbon dioxide. So carbon dioxide is obviously a really important waste product of metabolism. Here's our nice little cell over here producing lots of carbon dioxide as a waste product. Under normal circumstances, this carbon dioxide is going to be transported to the lungs, where it can be excreted essentially during expiration. So here are your lungs, and here's you puffing off that carbon dioxide. But in order to get to the lungs, we need to think of the process of how that carbon dioxide is actually going to get to the lungs so it can be puffed off and the carbon dioxide can be expired. So for transport to the lungs, for transport of our carbon dioxide waste product of metabolism, for transporting that to the lungs, it's either combined with protein or hemoglobin, as you can see here, or it's dissolved in plasma, where it reacts with water as per this equation over here. So carbon dioxide, which is produced by cellular metabolism, reacts with water in your plasma, producing H+ ions and bicarbonate. And this is a two-way reaction. So important. That is how that carbon dioxide is going to be transported to the lungs so that we can get rid of it. CO2 is generated and expired. CO2 itself can be seen as an acid, because obviously CO2 can produce bicarbonate and it can produce hydrogen ions, which contribute to that acidity. So any increase in PaCO2, so any increase in your partial pressure of carbon dioxide, is going to move this reaction to the right. You get more hydrogen ions being produced, and you get more acidemic. Does that make sense to everyone? This is a nice, hopefully straightforward flowchart. Just pop it in the chat if everyone understands that. I like to keep things simple, so hopefully this is nice and simple for everyone. Anyone else understand? Yes, good, fantastic, lovely, lovely. So now we need to move on to more about some other concepts within acidemia, alkalemia, and then thinking about more about along the lines of respiratory acidosis, respiratory alkalosis. Which of the following is not a cause of respiratory acidosis? Once again, hopefully not too complex. This webinar is not designed to be massively complicated. The next webinar on interpretation hopefully will be more complicated. But this is just in terms of getting a baseline understanding. Which of the following is not a cause of respiratory acidosis? Okay, I'll give you a few moments. Look at the chat. Okay, let's have a look. Good. Good. And really, this is testing our understanding of the previous slide and putting it into clinical practice now. Because we said anything that's going to cause an increase in your PCO2 is going to cause acidemia. Well, you know, where's my mouse? 1, 2, 3, 4. These 4 here are going to cause an increase in your PCO2. And I'll explain why on this slide. So the reason anxiety does not cause respiratory acidosis is because anxiety is associated with what we call psychogenic hyperventilation. So you get very anxious, start shaking, you start sweating, and along with that process, you go and you're puffing away and you're puffing off so much carbon dioxide. If you're puffing off all that carbon dioxide, obviously your PCO2 is going to be low, and that causes alkalosis, not acidosis. Whereas as described underneath here, all these other conditions can cause a respiratory acidosis because of an increase in your PCO2. So hopefully everyone understands that, because that's very important to try and tie that into clinical practice. Now, this is linked in to our previous conversation about respiratory acidosis. So we need to think about anything that's going to increase our PCO2 can cause respiratory acidosis. So when you have a reduction in your ventilation, so a reduced alveolar ventilation, essentially, that is going to reduce your excretion of CO2, obviously. And that obviously then was going to cause an increase in your PaCO2. And as we remember via that lovely equation we looked at, that's going to cause a production of more hydrogen ions, and that causes acidemia. But because we're thinking about respiratory here, we call it a respiratory acidosis. There are lots of potential causes of respiratory acidosis. Here are a few highlighted. If one condition causes respiratory acidosis, it doesn't mean it can't cause alkalosis as well. So, for example, not all cases of pneumonia are going to cause a respiratory acidosis. Usually severe pneumonias may cause a respiratory acidosis. And if you look back at your CURB score, where you take into account things like confusion, urea, respiratory rate, blood pressure, the higher your CURB score is, often the more severe your pneumonia is going to be, and then more likely you're going to have a significant respiratory acidosis. But really anything that is going to cause a reduced ventilation, for example, COPD, obstructive respiratory disease, which can cause reduced expiration of carbon dioxide, is understandably going to cause a respiratory acidosis as well. So hopefully everyone understands that key concept there. Conversely, you then need to think about what's going to cause a respiratory alkalosis. Well, here we go. Anything which causes you to puff off all of your CO2 is going to cause a respiratory alkalosis. So because you have an increase in your alveolar ventilation, like we talked about previously in anxiety, this can cause an increase in your excretion of CO2, but really only if you're excreting your CO2 faster than it's being produced. Because naturally, that's going to cause a decrease in your partial pressure of CO2 and a reduced concentration of hydrogen ions. And here are a few examples of conditions that can cause respiratory alkalosis as well. I'm not going to get bogged down in all of these causes right now. As I said, they're not entirely black and white. Not just because a condition can cause acidosis doesn't mean it can't cause alkalosis as well. But there are also others, things like toxins, being at high altitudes as well, can contribute to respiratory alkalosis. So really anything which increases your alveolar ventilation. So great. So we can move on. We've talked about pH, we've talked about PCO2. Let's talk a bit about bicarbonate now. Now, bicarbonate is the most important buffer to try and maintain that pH within that tightly controlled range. And bicarbonate can be considered the opposite of an acid, also known as a base. So that's a little bit more of GCSE chemistry coming in there. Bicarbonate is generated by your kidneys, as you can see here, and it's measured really easily with that arterial blood gas sampling that we've been talking about. As we've said, it can be thought of as the opposite of an acid, and these are a couple of really important reactions to be aware of. So bicarbonate, produced by the kidneys, bicarbonate can react with those hydrogen ions in your blood and can cause that reaction to move towards the left to produce carbon dioxide and water. And obviously that's part of that buffering process. And it's via this route, via this buffering with bicarbonate, that the vast majority of acids are excreted each day. So you've got H plus HC3O minus can then produce carbon dioxide and water, which is puffed out, obviously, via your lungs. But bicarbonate can also react with hydrogen ions to produce this little molecule here, which we're going to be talking about later. So that's what bicarbonate does, and that's why it's such an important buffer. And as you can see, tightly controlled range as well. So let's talk about this reaction first. We've already said, the lungs are so important in puffing off your carbon dioxide, and we know how it's transported within the blood itself towards the lungs. So this is a concept we've already talked about. But as we mentioned on the previous slide, 90% of acids are excreted via this mechanism. So hydrogen ions, which if in excess is going to produce your acidemia, reacts with your bicarbonate, which is produced by your kidneys, to produce carbon dioxide and water, the carbon dioxide which is puffed off via your lungs. Nice and easy. Now we've got this other reaction here as well. So we've got hydrogen ions, bicarbonate, H2CO3. I'm not going to talk too much about that now because I might give away a few of the questions later on. But essentially, bicarbonate is going to be neutralizing that reaction, or neutralizing the effect of those hydrogen ions, and prevents a decrease in your plasma pH. So we've got that reaction taking place in your blood, and in the kidneys, actually that reaction is going to reverse. So you've got H2CO3 in the kidneys, that reaction reverses, which is actually really, really useful. Because when that reaction, well, obviously this is taking place in your plasma, H plus bicarbonate to H2CO3, when it gets to the kidneys, that reaction goes towards the left. And why that's so useful is because H plus ions can then be excreted in your urine, which is part of that buffering process, and the bicarbonate can then be filtered and returned back to the plasma. And it can be used as a buffering agent again. And that's how the kidneys work, and that's how bicarbonate works, and really in a nutshell. So just popping back two slides, that's why these two reactions are so important. Because on the left here, that's how we puff off carbon dioxide via our lungs. And on the right here is that reaction which takes place both in the blood and the kidneys. But in the blood, it moves to the right, and in the kidneys, it moves to the left, so that you can remove your hydrogen ions in your urine and that bicarbonate can be recycled. That's a little bit more complicated than some of the previous slides, but is everyone on board with this? Does everyone understand this physiology that I'm talking about? Yeah? Everyone happy so far? If you don't quite get it, just obviously all these slides are going to be recorded, have a listen back as well, and everything should be cleared up. Good. So now we need to think about contexts where there's an acute increase in your acid load. So what do I mean by an acute increase in your acid load? So if a patient is acutely unwell, if they have, if they're septic, they're going to have potentially a lactic acidosis, loads of lactate being produced by anaerobic respiration. Now, anything that causes an acute acid load increase, a few things are going to happen. The respiratory system, so your lungs, are going to try and compensate by increasing ventilation and excreting carbon dioxide. And naturally, bicarbonate will decrease as it tries to buffer that extra H plus that's being produced. So two things are taking place. Your lungs are puffing away up carbon dioxide to try and maintain the pH in that narrow range. And at the same time, you've got bicarbonate in your blood reacting with hydrogen ions, and that bicarbonate is going to decrease as it buffers with that extra hydrogen, those extra hydrogen ions. But once those bicarbonate reserves are used up, those bicarbonate reserves are gone, H plus will obviously accumulate and the pH will decrease. So essentially, if the kidneys are unable to produce sufficient bicarbonate, you then get a resultant metabolic acidosis. And that's why these two systems are so important, and they work essentially synergistically. But there are a couple of issues with these two processes. So let's talk about that as well. We've talked a lot about the kidneys, and we've talked a lot about how the kidneys produce bicarbonate, how bicarbonate is such an important buffer and works synergistically alongside the lungs to maintain that tight range. But how long does it take for the kidneys to effectively respond to increased hydrogen ions? Now, this is such an important question in clinical practice as well. If a patient is acutely unwell, over a space of hours, are the kidneys going to be able to respond to that increased acidity, the increased hydrogen ions being produced? How quickly do the kidneys respond? And really read the question carefully. How long does it take for the kidneys to effectively respond? So pretty big split there, pretty big split. Correct answer is 3 to 5 days. And I'm going to touch on why that's so important in a sec. So we've already talked about the kidneys excrete H+, the kidneys buffer by producing bicarbonate, but maximal effectiveness takes 3 to 5 days. The kidneys are pretty slow, whereas the lungs are really quick. And that's really important. The kidneys do start responding within hours, but it's that effective response which takes 3 to 5 days. And now the question is, why is that so important? So let's talk about that. So bicarbonate, we've touched on metabolic acidosis, and we're going to be talking about metabolic alkalosis as well. So if the kidneys fail to produce sufficient bicarbonate, you get metabolic acidosis. For example, if a patient is, we've got a few examples here actually, if you've got diabetic ketoacidosis, which occurs not massively acutely, but relatively acutely, if the kidneys are not able to produce enough bicarbonate to manage that increased keto acid production, you're going to get a metabolic acidosis. Because although the lungs are puffing off, you get things like cosmal breathing, etc., because the lungs respond really quickly. The kidneys are a bit sluggish. Here you go, a kidney with a snail on the left of it, because the kidneys are a bit slow. And that's how metabolic acidosis occurs. Metabolic alkalosis, there are a few causes here, usually things like if you're vomiting significantly high output fistula, if you're losing lots of hydrogen ions, you can get a metabolic alkalosis. But the main consideration is going to be metabolic acidosis. Really important in clinical practice to know the causes, to know the physiology as well. But obviously there are also a few things that can cause iatrogenically metabolic alkalosis, such as thiazide or loop diuretic use as well. So hopefully that makes sense to everyone. But this is a really important point: is the sluggishness of the kidneys to respond to changes in your hydrogen ions within the blood. Okie dokie. We've talked about that. We've talked about that. So that's brilliant. So now we need to move on to this other really important concept of base excess. Base excess is a concept which people often are a little bit confused about, but it's actually relatively easy to understand, I hope. So these are a couple of definitions, which I'll read to you quickly here. So base excess, from a theoretical standpoint, it's just the measure of the amount of excess acid or base that is in the blood as a result of a metabolic derangement. In other words, it is the amount of strong acid or base that would have to be added to a blood sample with an abnormal pH to restore it to normal. Sorry. So that really is the important thing. It's the amount of strong acid or base that would have to be added to a blood sample with an abnormal pH to restore it to normal. So normally it's going to be +2 or -2. So +2 millimoles per liter or to -2 millimoles per liter of strong acid or base that would need to be added to your blood to restore it to normal pH. That is that normal range. This makes a little bit more sense when you start considering it clinically, I guess. So I popped a couple examples here. So if we look at the top here, we're going to be thinking more along the lines of base, significant base excess, more than 2 millimoles. So if you have a base excess of 7 millimoles per liter, that essentially means that you require 7 millimoles of strong acid to return your pH to normal. And obviously, if you need more strong acid to return your pH to normal, that means you essentially have a metabolic alkalosis because you have too much bicarbonate. They have too much bicarbonate, which means hypothetically you would have had to add more acid to that blood in order to return the pH to normal. So anything which causes a raised base excess above 2, essentially you're saying this patient has metabolic alkalosis. You'll look at the bicarbonates and the bicarbonate should be elevated. And therefore that's going to be saying you've got a metabolic alkalosis is associated with a base excess of greater than 2. Because you're essentially saying you need more strong acid to neutralize or to return that pH to the normal range. Conversely, if you have a base deficit of 7 millimoles, so -7, you're essentially saying that you require 7 millimoles per liter of a strong base to return that pH to normal, which is essentially saying you have a metabolic acidosis. And if you have a look at your bicarbonate, that is going to be reduced. This is really all you need to do is listen to this slide a couple times and read the words precisely here, because theoretically it can be a little bit complicated to get your head around. But if you just want to learn the facts, then if you have a raised base excess of above 2, you're thinking metabolic alkalosis and correlate that with the bicarbonate. If you have a base deficit of less than -2, you're thinking metabolic acidosis, and the bicarbonate is going to be reduced. Now, annoyingly, in clinical practice and in medicine, the term negative base excess is used instead, which I think is an absolutely ridiculous phrase to use, but it is what is used. So that's actually used instead. So I much prefer saying base deficit because it makes a lot more sense, but technically negative base excess is the technical terminology when you're saying instead of base deficit, but it's the same thing. Yeah, so that's always really important to look at. When I work in A&E and I'm looking at blood gas samples, if you're looking at the bicarb, you need to look at the base excess because hopefully, those two should correlate, and then you can actually say, is this a metabolic acidosis? Is this metabolic alkalosis? And then it's always useful to correlate that with the lactate as well. Okay, last question of the day. We don't have a top decile one today just because there's not much clinical stuff going on here. But next time when we look at interpretation, of course, we will. So which enzyme is responsible for the respiratory-metabolic link in compensating for changes in pH? Which enzyme is responsible for the respiratory-metabolic link in compensating for changes in pH? So would base excess effectively just be used to qualify how severe a metabolic acidosis or alkalosis is rather than to make a diagnosis? That's a very good point, Manasvi. I guess having it's a significant base excess or significant base deficit in and of itself is not going to diagnose anything. But like you're saying, if you take that into account in the context and you look at, we're going to talk about interpretation next time, but if you look at the bicarb alongside the PCO2 and alongside the pH, you're absolutely right. It will help you give an indicator of the degree of metabolic acidosis and alkalosis alongside that bicarbonate. And that's why it's so useful. But we'll talk about it alongside bicarbonate in the interpretation webinar. Okay. So 63% have said carbonic anhydrase, and you would all, oops, sorry, the correct answer here is carbonic anhydrase, not carbon monoxide dehydrogenase, carbonic anhydrase. Good. So if we remember back at a couple of those reactions we talked about, one of these was the conversion of CO2 and water into H2CO3 minus, which is carbonic acid. That is facilitated by carbonic anhydrase. And that's such an important enzyme because that is involved in what we call the respiratory-metabolic relationship, which is the last concept to touch on today in our last few minutes. We've already kind of spoken about this already. We know this reaction, hopefully, back to front now. We've got CO2 and water to bicarb, and then we've got hydrogen and bicarb to, CO2 and water to H2CO3, and H plus and bicarb also can go to H2CO3, and then they're both obviously synergistic and can work back and forth. And as you can see, that link between respiratory system and metabolic system is via carbonic acid, H2CO3. Obviously, you puff off your CO2 via your lungs on the left, so that's respiratory system, and bicarb is your lovely buffer produced by your kidneys, and that's your metabolic system. And that link there is provided via carbonic acid. So one example, which is kind of the last couple of slides now, to demonstrate that respiratory-metabolic relationship, and this is where things get a little bit more complicated, but it's really important for clinical practice. Let's think about COPD. COPD, chronic obstructive pulmonary disease, you get reduced excretion of CO2, obviously, and you get respiratory acidosis because you get a buildup of CO2 and your pH drops. Now, unless you have some kind of synergistic relationship between your respiratory system and metabolic systems, this would then result in persistent acidemia in all COPD patients. But that doesn't take place, does it? Because we have these compensatory mechanisms. So although respiratory acidosis is associated with raised CO2 and COPD is associated with raised CO2, we have this lovely reaction here, CO2 and water, carbonic acid, hydrogen ions, and bicarb. And it is this process and that link via carbonic acid which prevents these patients from having a persistent acidemia. So we've got these reactions taking place. You've got hydrogen ions in your blood. We've talked about why this is so important, because although your lungs are struggling to puff off all of that carbon dioxide, this can then be compensated via your kidneys, because you have a respiratory acidosis, which is due to increased PaCO2 because you can't puff off of your CO2, but you get a compensatory metabolic alkalosis because your kidneys produce more bicarbonate. Your kidneys, as well as producing more bicarbonate, they excrete those excess hydrogen ions, and then the pH will return to almost normal. And that is that relationship which is actually described by that equation right at the top there. Because without that, these patients would struggle to survive because they'd have a persistent acidemia, which would essentially just get worse and worse. And that's why your kidneys need to talk to your lungs. And that's now moving on to that final concept of compensation. The respiratory acidosis with compensation by your kidneys, metabolic alkalosis. And we're going to talk more about that next time. So well done everyone for sticking around all the way to the end. We've covered a huge amount. And in terms of physiology, that's really all you need to know to understand our interpretation webinar, which is going to be coming up soon as well. So we know what an ABG is, we know the general sites we do ABGs. We've talked about the differences between VBGs and ABGs, whether that's in terms of practicalities, but also correlation. We've talked about pros and cons of ABGs. We've talked about a few examples of when you're going to need to do an ABG. And we've talked about all of those parameters and that physiology. We've talked about a lot today. So have a break, rest, digest, and relax at home. Thank you everyone for sticking around till the end. I really, really hope you guys found that useful. Stick around for our ABG interpretation webinar coming up soon. We have our big conference, I don't even know if it's a conference, like big lecture series, whole weekend with Schwaber and I are taking place at the beginning of December. So go to BiteMedicine.com and check out the events tab there, and you can sign up and you can join us for a whole weekend of learning lots of cool stuff. But absolutely great to see so many of you here today. Now we're all back in lockdown. And do sign up for that weekend because it will be good fun. Just looking at the chat, thank you so much for everyone's kind words. Thank you for staying till the end. There's no feedback form today, but we'll do a joint feedback form next time. The slides, I will triple check and make sure they are uploaded really soon. Thank you. I'm glad everyone really enjoyed it. The interpretation talk probably will take place next week, but I will need to double check. We've got imaging coming up soon, imaging part 1, imaging part 2, so chest x-rays, abdo x-rays coming up soon. And so do check the timetable. I can't remember off the top of my head when that is, but please do tell your friends, tell your family about us, because that is how we survive. And the recording will be available within the next 24 to 48 hours. We just need to make sure it's all chopped up and sorted out properly. So that should be up soon as well. And the slides should be up already, but if not, I'll get that sorted. Cool. Any other questions? Anything else anyone would like to tell me in the chat before we finish off? Otherwise, I will wish you all a wonderful afternoon, or evening or morning, depending on where you are in the world. Fab. Anyone else? Any questions? Thank you so much, everyone. Please do sign up for our weekend, and we'll hopefully see lots of you there for that weekend medicine and surgery extravaganza. Could you please explain the lactate dissociation again? All I'm assuming you're referring to is the fact that with venous blood gases, it's been found that once your lactate is above 2 millimoles per liter, the correlation between venous blood gas lactate and arterial blood gas lactate, that there's a slight dissociation there. However, often that is not going to be clinically significant, that dissociation. So that's really all it's referring to. If a patient is significantly unwell on a venous blood gas, their lactate is significantly elevated, it's going to be significantly elevated on their arterial blood gas, and it's unlikely that any dissociation there is unlikely to change your management. Any other questions? Any other thoughts? Anything anyone would like to ask me or tell me? Otherwise, we'll close up, and I'm going to grab a cup of tea. Cool. Take care. Have a great afternoon, and look after yourself. Stay safe. Goodbye.